Good morning, and it is Fun with Fractional. So this is going to be a little introduction. This is going to be a nice little primer for my colleagues who will be speaking about their individual devices and energies, but just to give you a little taste of fractional therapy, the history of it, and whatnot. These are my disclosures, none which are relevant for this talk. And so getting right into it, so fractional photothermolysis was a concept that was introduced in 2004 by Rox Anderson and Dieter Manstein, and it revolutionized the field of skin rejuvenation. Essentially, you have an array of pixelated light energy produced with each scan or stamp of the laser that creates these microscopic columns of thermally denatured skin. We sometimes refer to them as microscopic treatment zones or microscopic or microthermal treatment zones, and they're surrounded by normal, unaffected skin. The targeted damage within those microthermal zones is then believed to release pro-inflammatory cytokines and growth factors that leads to neocollagenesis and collagen remodeling. So the original non-ablative fractional resurfacing device was described, again, that was described by Manstein and Anderson, was a 1550 nanometer wavelength. The one that we're most familiar with today is the Fractional Dual, which combines your 1550 nanometer erbium glass laser with a 1927 thulium laser. The thulium laser is going to provide a more superficial treatment, and your 1550 is going to provide a deeper treatment with more collagen remodeling. This device is going to have tunable settings, and so one thing with fractional therapy that you'll hear throughout this talk, and probably with my colleagues, is everything will be dependent on your settings and parameters that you set for each treatment. Okay, here. Oh, let's see. Okay. So microscopically, what we're seeing with fractionated laser therapy is going to be a controlled denaturation of the transepidermal elimination of that coagulated debris, which is within that sharply defined column that you created when you laid down your passes. The most prominent effect is going to be the formation of the microscopic epidermal necrotic debris, or what we refer to as MENS. And so the MENS will slowly start to be extruded through the epidermis as early as 24 hours post-treatment. Usually when we talk about fractional therapies with our patients, we'll sometimes let them know that they may notice a little bit of flaking or dryness of the skin, and that flaking actually correlates with those MENS being extruded through the epidermis. It usually takes about 5 to 7 days for full completion, but again, it explains the elimination of either the pigment within the skin you're targeting or some of that altered collagen that we're trying to address with patients who want to improve their overall facial rejuvenation. The beauty with fractionated therapy that we love is that you can actually have collagen remodeling up to 6 months after your treatment, so it's kind of the gift that keeps on giving. So with the indications, you can use fractionated resurfacing for many different things. In my practice, I most often am using fractionated resurfacing for acne scars, either hypertrophic or atrophic scars, scars with pigmentary alteration, and skin resurfacing. Again, the advantages are going to be that we have that continued remodeling 6 months post-treatment. There's a reduced risk of complications with your fractionated therapies, and minimal downtime. So depending on your settings, you may tell your patients that whatever your target treatment is, they may have 1 day to 2 days of maybe some erythema, a little bit of swelling. Sometimes, again, if your settings are going to be more aggressive, the downtime can get into the 7 to 10 day range. But that advantage with your fractionated therapy is minimal downtime. So when you get into thinking about the parameters, you first have your wavelength, and then your second parameter is going to be your pulse energy. And so this is going to control the depth of what you're treating. And so here you can see an example of how you're going to increase your energy, which will control that depth based on what you're trying to treat, whether it's more superficial and it's pigment, or whether it's going to be deeper and it's more like acne scars or surgical scars. Another parameter is going to be the density, or the percent coverage. So this controls the percent of area treated, or the number of channels per skin area. And so again, your downtime will be affected by the density that you set and how close you're putting these columns together, also the number of passes that you're doing and the area that you're treating. So when it comes to the different motions that you see with some of our devices, you have stamping hand pieces and you have continuous motion hand pieces. So the stamping hand pieces, let me make sure this other, okay, here we go. The stamping hand piece is going to be delivering the fractionated energy according to the tip size. And so essentially we lift it off the skin between each pulse. We really do not recommend pulse stacking. Sometimes depending on the tip of your device, you have to take into account a small area of overlap so that you can have continuous treatment throughout that area. But oftentimes with fractionated therapies, we usually recommend no more than 50% overlap. With the scanning hand piece, again, there's a continuous motion of that linear pass that's delivered. You stopped, you'll lift the device, and then you will pass over the next area to provide a full treatment area. So these are going to be the differences with our fractionated lasers, because we have both non-ablative and ablative lasers. With your ablative fractional lasers, you're going to get that vertical column of vaporized tissue, but it's going to be both in the epidermis and the dermis, versus your non-ablative devices where you're going to have that microscopic column or targeting mainly, the heat is going to be delivered more to the dermis, sparing the epidermis. Again, you can dial up or dial down your treatments with fractionated devices, and that is also going to be customizable to what you're treating. But again, with your non-ablative devices, you will have that decreased downtime, risk of infection, pigmentary alteration, etc. So this is by no means a comprehensive list, but this is a general list of a lot of our non-ablative fractional devices and their wavelengths and their manufacturers. And then we also have our ablative devices as well. So with fractionated therapy, setting the patient's expectations and what to expect is going to be key to also the success of your treatment. The consult will be very important in talking with the patients on showing them before and after photos, also talking with them on exactly what they're going to be seeing during that healing process. I found his help to give them the expectations of what to expect, how much flaking they may have, that it's not anything, that it's not necessarily a concern that they should be worried about, and also just making sure that they're going to be compliant with their post-care regimen. Again, I always like to make sure that my patients are compliant with their sunscreen prior to treatment. Whether or not you start oral antibiotics for your fractionated treatments is going to depend on the treatment and how aggressive you are. Generally, prophylactic antibiotics are not recommended for a lot of non-ablative treatments, especially if you're doing small areas. I tend to do when I'm doing acne scars or resurfacing, I tend to be more aggressive, so I always will put my patients on prophylactic antibiotics. Antivirals are definitely recommended for your patients that have a history of HSV infections. Whether or not you decide to treat your patients with either lightening agents or having them stop their retinoids, that may depend on your training. It may depend on, again, the settings that you're thinking of doing with their treatment concerns, but I think some of us are mixed on that. And then also just taking into account that we do have our 2017 consensus statement from our colleagues that does say that for fractionated treatments, whether they are ablative or non-ablative, it is okay if our patients are on oral isotretinoin or if they have been on it within the past 6 months, it is okay to still do those treatments. The only indication where you don't want to do it is if it is going to be fully ablative resurfacing. So oftentimes if I'm treating acne scars and I have a patient with super oily skin, I sometimes will recommend that we put them on isotretinoin prior to their treatment, because depending on their post-treatment occlusive ointments, I'm trying to minimize any additional acne breakouts. When you're thinking about the actual treatment that you're doing, your key points to remember are going to be delivering your settings in an optimal time frame. You want to make sure that you're allowing enough time to pass between those passes, not having a lot of bulk heating. This is a general treatment table that was from the 3rd edition of the Procedures in Cosmetic Dermatology that gives you some different settings based on what you're treating. Keeping in mind that if you're treating darker Fitzpatrick skin types, you will want to adjust your settings as well. Although complications, especially long-term ones, are really rare, patients should be educated to expect, some typical side effects that may include some mild swelling, some redness or erythema, and again, that dry skin or desquamation. It usually will last for 1 to 3 days, again, depending on how aggressive or not aggressive your treatments are, and then just some of the others that we have listed here. This was a study where they looked at 422 patients with a total of 961 treatments who had non-ablative fractionated resurfacing, and the most common complications were either acne eruptions, HSV outbreaks, or erosions. And oftentimes the acne outbreaks were likely in patients who are acne prone, and so again, they recommended considering oral antibiotics. Again, I like to do oral isotretinoin to minimize that. With some of these, within this study, they did look at the treatment settings that were used on darker Fitzpatrick skin types, and one key point to remember is that you can definitely minimize either post-inflammatory hyperpigmentation or other pigmentary alterations by adjusting your settings, especially your density with your treatments. And I think some of my colleagues are going to go into that. With post-treatment considerations, again, you want to review that recovery timeline. Again, sometimes it's just going to be a very mild post-treatment balm versus my second patient here, she has an occlusive ointment on her entire face because I did do a fractionated aggressive setting for her fractionated resurfacing. So these are just some nice take-home points as we get into the meat and potatoes of our session today here, where we're going to go into all of these individualized devices and treatments. But these are some take-home points, again, from procedures in cosmetic dermatology, talking about just when you're considering dyschromia versus darker Fitzpatrick skin types, the recommendations for topical retinoids, pre-treatment options, et cetera. So it's a great source to have. I think one of the main things to remember is that your settings are going to be everything when it comes to fractional treatments and what you are trying to target with your patients. And I finished on time.